I won't tell you what they are because this is what the expert speakers are for. We have three excellent speakers to come. So I think I'll introduce everyone in turn. So our first speaker is Caroline Copeland. And so, Caroline, please do take the stage. Please introduce yourself and tell us about nitazenes.
Great. So I'm Dr. Caroline Copeland. I'm an academic at King's, where I'm a senior lecturer in pharmacology and toxicology. And as part of that, I run what is known as the National Programme on Substance Use Mortality, which I'll be telling you a little bit more about shortly. But it's a database of deaths related to drug use that's reported to by coroners. But today we are looking at nitazenes and then some of the data that I have collated from the database that I run as well. Some people say nitazene, some people say nitazene. I say nitazene because when you say the full name of them, isotonitazene, metanitazene, protonitazene, so on and so forth, you don't say protonitazene and isotonitazene. So I've gone for the nitazene one, but I don't think either's particularly right or wrong. So these are a class of opioids, which means that they act at opioid receptors along with other opioids that we know about, so heroin, morphine, codeine, fentanyl. It's all within that class of drugs. And one of the key things about the nitazenes is that they are synthetic, which means that they are able to be made in a laboratory. In order to make them, you start off with some quite basic chemicals that you then make into one thing, and you take those and combine and go on and so on and so forth. But because of this, it's really going to be very difficult to control the precursors for nitazenes, as has been done for things like fentanyl precursors, because you can just keep on going back in the chain to some substances that are widely used in the manufacturing and chemical industries. So it's going to be very difficult to control the manufacture of these substances through controlling their ingredients, essentially. Interestingly, they were actually first developed as medicines in the late 50s, early 60s, alongside the fentanyls, because essentially they were being investigated to be alternative analgesics, but they were found to be so potent that the risk of overdose was just too high, and the therapeutic window between being useful and then being dangerous was so close together. And yes, they are extremely potent and incredibly dangerous. And between 2019 and 2023, the UN Early Warning System has reported 13 different nitazenes that have appeared both in the UK and abroad as well. So to give you an idea of their potency, if we can say that the relative potency of heroin is 1 and that of fentanyl is 50 times as potent as heroin. So we know that fentanyl is very dangerous and it's caused quite a lot of trouble in the US. And then we have a look at the potencies of some of the nitazenes that we've seen here in the UK. And things like metanitazene, I don't think the word weaker is probably appropriate here, but the least strong maybe. Nitazene is about the same potency as fentanyl, up to etanitazene, which is 500 times more potent than heroin, 10 times more potent than fentanyl. Earlier last year, I had a BBC documentary wanting to film something, and I wanted to put into sort of glass vials the amount of table salt that equated to a fatal overdose of heroin, fentanyl, and one of the nitazenes. And I was getting my PhD student to weigh them out, and he was literally trying to find the smallest grain of salt that he could to put in this bottle, because that was the amount that would prove fatal for a nitazene overdose. Okay, so unfortunately, we know that the nitazenes are here in this country. The database that I run, the first death that we had reported to us was in 2019. There were none in 2020, but then we had, I think, 13-ish in 2021 and just over 20 in 2022. But there was obviously that big spike in 2023, which has really garnered the level of concern that we now have. But this storm has been brewing for a while. We're often asked, or I'm often asked anyway, why do we have nitazenes in the UK and not fentanyl? Fentanyl clearly endemic now in the US heroin supplies. Now, I think there's different push and pull factors, and I don't think any one of these is a particular answer. But one of the reasons might be that when the Taliban returned to control, for the majority of Afghanistan in 2021, one of the pledges that they had was to ban the cultivation of the opium poppy from which heroin is derived. And what this figure is showing here on the left and the right is that the pink areas, which are the poppy fields from 2022 to 2023, have almost entirely been eradicated. And what we think has happened here is that the organised crime gangs were spooked and thought, well, if we aren't going to get our heroin from Afghanistan anymore, which is the source of heroin to, or was the source of heroin to the majority of Europe and the UK, what else can we use? And I'm sure fentanyl probably crossed their mind, but the Mexican cartels which supply the US with their fentanyl essentially have sort of the global monopoly on fentanyl precursor. And I think if an organised crime gang in Europe was trying to go into business competition with some of the Mexican cartels, they might not be alive for very long. So I imagine they were starting to look for alternatives, which is where the nitazenes may have come from as a result. As it turns out, quite a bit of heroin has still been coming out of Afghanistan because there was quite a lot of stockpiling happening, but it is much more expensive and it is a limited product as well. So although it hasn't seemed yet to have run out, it is something going forward that will probably not be in supply for much longer. So nitazene deaths in the UK, sadly, there have been quite a few of them. These were the figures last year from the NCA, where they estimated in the single year there'd been 230 fatalities. I think that some recent figures from last week was something like 400. And I've heard people say things like there's been a death a day due to nitazene use in the UK since summer 2023. We've not had all of those deaths reported to the database I run, but the ones that we have had reported thus far, we've put on this map here. The reason we aren't reported all of the ones yet is that the time taken between death and conclusion of coronial inquest, which is when we're reported to, varies from 3 months in one of the quickest jurisdictions to over 2 years. So being early 2025 at the moment, we might not have actually received all of the 2023 deaths until later on towards the end of this year. So that's one reason. And we also don't get reporting from all coronial jurisdictions in the UK. We do get over 85%, 90% of coroners reporting to us, but it's not 100%. But what this map is showing is that whilst there are hotspots, particularly in the Birmingham region and along the south coast, it's not that this nitazene problem is located to certain areas. It's spreading across the country. But my concern with looking at the data is that the number of deaths could be even worse than what is already a scary situation. What this has come from is running the database. I talk to a lot of the coroners in the country, but also a lot of the toxicology labs in the country that process the post-mortem samples, which test for drugs like nitazenes. And we've had some weird things happening. And the first one was in 2023, after that first spate of deaths in the summer of 23. There was one toxicologist who was reporting nitazene being detected in urine samples from people who had died, but not in the corresponding blood samples. And the drugs that were detected in the blood samples weren't in quantities that would normally be associated with fatality. So this chap was trying to look at what else was in the blood and trying to see, had there been nitazene in the blood that had then degraded, that then wasn't being detected, which is why it was only being detected in the urine. But, this could also be dismissed of just non-recent nitazene use. So drugs stick around in the urine much longer than they do in the blood. So it could just have been that they had used nitazene a couple of days prior and then something else which had caused their death. So that didn't raise too many eyebrows at this point, but then more things happened, including this one here, where there has actually been 2 cases of this now, where somebody that had died, a very rapid blood sample was taken. This is quite unusual for a post-mortem, an autopsy to take place the day after someone had died, but clearly that not a lot of work for the pathologist that particular day. And a day 1 sample was taken and sent to the lab, and they tested it and they detected nitazene. And they were like, oh, well, what would be nice to do is not just the is it their test, but the how much is their test, so the quantification of it. But they didn't have enough blood sample left. but the body was still in the morgue. So they went back to it and said, can we have another blood sample, please? And absolutely, here you go. But no nitazene could be detected at all in that day 7 sample. And it also happened in another case, I think, where the blood was taken, the second sample was taken on day 8. So in day 1 samples, the nitazene was detectable, but in day 7 and 8, which is when a lot of postmortems are done, the nitazene was no longer detectable at all. We then also had reports of nitazene being detected in preserved blood samples where they've been put in a vial with chemicals that preserve the contents of drugs that might be in the blood, but had disappeared in the unpreserved samples that had been also submitted. And then also a case where somebody had been found dead with a needle in their arm, which was found to contain, or include, I should say, one of the nitazenes, metanitazene. But when the blood of that person was tested, there was no nitazene detectable. Now, it's very possible that that needle had been placed post-mortem and hadn't actually been used, or had been reused, and someone else had used it and administered metanitazene, and this person hadn't. So it's possible that they hadn't administered it and it was just an incidental finding. But taken all together, it was building up a story to me that maybe we're missing deaths due to nitazene because they're unstable at the point in the blood, and at the point of testing that they're being undetectable. We went to the database that I run, so this is it, the National Programme on Substance Use Mortality. These are the areas that we have reporting to us in green, and in red the ones that don't. If you know anyone from those red regions and have any form of influence over coroners, to tell them that the work that we're trying to do is just to prevent drug deaths and that their data is incredibly important, it would be much appreciated. The database has been going a long time, over 25 years, over 54,000 deaths. I think we actually did an update, we've got over 58 now. Which is a very sad number that keeps climbing. And we are reported deaths due to psychoactive drug use from across the country. And it's a very rich data set. We get an awful lot of information about the people that have died, much more information than is available to the Office for National Statistics, for example. For these this sort of disappearing nitazene question, we chose to look at all deaths in the Birmingham Solihull region over a number of years. And the reason that we chose this particular jurisdiction to do this modelling in was twofold. First is that we know that there was a contamination of the heroin supply with nitazene in the summer of 2023, and a quite significant one. So it was an area that was a known hotspot for what had been nitazene availability. And it's also the area in the country that has the fastest turnaround time between death and conclusion of coronial inquest, which is when the database is reported to. And by the time we did this extraction in November of 2024, so just a few months ago, we could be pretty sure that we'd had all of the deaths from 2023 reported to us. And the first thing that we did was we took all deaths from 2019 through 2023. And we separated them out as to whether or not there was or wasn't a nitazene detected. So in orange here along the bottom, we've got, I think, 1 or 2 deaths in 2021, but then over 40 now in 2023 that's been reported. But then if we look at the non-nitazene deaths, which is the one that's in green here, we can see that there is a spike in deaths in 2023 beyond what would potentially have been predicted based upon the previous trend. And what we've done here is a mathematical technique called an exponential smoothing model, which sounds very fancy, but it's quite simple, really. And what you do is you feed in the data from 2019 to 2022, and you say, right, this is what happened then. Based upon the history, what do you think is going to happen next year? And the computer comes up with a number, which was this one here, the solid light green line. But then you also say, yeah, but how sure are you about that prediction? And they go, well, we're 95% certain that it will fall somewhere within this shaded region. So that's sort of the middle of where we think it's going to happen, about 110-ish deaths. But anywhere within here is sort of the rate of variability that would be acceptable to this prediction. But what we've got in 2023 is this marked 30% increase in deaths above what could have been predicted. So this is not looking good. Now, it could be that Birmingham was very unlucky in 2023 and they had another drug that was causing people to die at an increased rate. It could be that people were changing their drug use patterns. But I think that would be very unlucky for two big things to have happened in 2023 in the same place. So my money is on that these nitazenes were present in some of these deaths, but by the time the blood had been taken and it was tested, that it had degraded beyond the limits of detection of these toxicology tests. So it's very possible that those 230 in that time frame is actually looking more like 300 deaths, and of the 400 that are now being reported, is that over 500 deaths that might actually be happening. We then did some additional modelling as well, looking at separating out these total deaths into cases where heroin or morphine had been detected, or absence of a strong opioid. The ones in yellow here are the heroin deaths. And again, we've done this modelling, and the number of deaths due to heroin was above what could have been predicted based upon the previous trends. But the deaths due to other substances, towards the upper limits of the model, but still within the variation that could be expected. So there's a specific increase in heroin deaths beyond what could be anticipated in the absence of nitazene. So it's also important to highlight here that we think from the evidence that's available that nitazenes are a problem for more than just heroin users. And I think Judith's going to be talking a bit more about Wedenoff data shortly. But for those of you that aren't aware of Wedenoff, this is a Welsh initiative where they accept samples of drugs from the public that can post them in. And the public say the first half of the postcode for where they're located and what it is that they thought that they were buying. Wedenoff then test it and post online what it was that was actually detected. And looking at the submissions to Wedenoff where nitazene or anitazene was detected, we can see that there are many more detections happening in 2023, and that had already exceeded the number of submissions that contain nitazene for just over half of the year than there had been in the entire of 2023. But when we look at the things that people thought they had been buying that contained nitazene, the number one was not actually heroin. It was counterfeit, fake diazepam and oxycodone tablets at 52% of submissions and 20% of submissions respectively. Now, you need to be careful with how you interpret Wedenoff's data. You could say, gosh, well, there's more nitazene in fake diazepam and oxycodone than there is in heroin. But you need to be careful with the submitter bias. To submit to Wedenoff, you need to print out a form and fill it in and post it. And I feel like I'm a grown adult woman that is, owner of a home and so on and so forth. But I don't own a printer. And if I want to print something, I have to go to work and use that one. Don't I work? But you've got to think about who's actually going to be submitting this as well. And so I think that there's fewer people who use heroin who are submitting samples than maybe those that have bought counterfeit tablets off the internet. So there is a submitter bias there. The take home here is it's not just a problem for heroin users. Okay, so that's all from me. So nitazenes are here and they're possibly here to stay. There are some people that say, well, what if the heroin supplies recover, or if there's more planting in Myanmar of opium poppy? But unfortunately, I think that the organised crime gangs have probably learned that these nitazenes, they're fairly easy to make, they're fairly cheap to make, and they're easier to smuggle as well because they're so potent. You only need a tiny amount in a greetings card to ship them over the border. And if we were terrible at keeping heroin and cocaine out of this country, which we are, and that's bulky product, we're going to be even worse at trying to keep out tiny amounts of powder in the post. We also know that they're found throughout the UK and European drug markets, and it's not just a heroin problem, it's across the different drug types as well. And there's also this idea that they may be unstable in post-mortem blood samples, and so the amount of the deaths that are being caused by them that might be being underestimated massively. In a previous life, I was a rodent physiologist, and I've actually done some experiments with some rats to test this post-mortem degradation idea. I literally got half of the results through a couple of days ago, earlier this week. It's not finished yet, but the few samples that we have had through are showing that they are degrading by up to 60% between a day 1 and a day 7 sample. So they do look like they are disappearing. But I'll have more data on that shortly. Okay, that's everything from me. I do have to acknowledge other people though. Skye and Adam did lots of the modelling, and Simon and Rob and Claire have helped with a lot of the toxicology analysis. So it's certainly a team of people. And I'll just put my email up there as well. I know this is being recorded, but if you have any questions or would like to contact me, do let me know.
Thank you very much for that, Caroline. That was really, really interesting. And I'd say wonderful data, although pretty grim. So we've got already quite a few questions. Mainly, I'm going to save them till afterwards. There's one I'm going to put to you now, Caroline, which is really a clarification on the data. When we look at the comparisons in strength, are we talking about pure heroin or street heroin?
So that is the sort of the pharmacology definition of potency. So if you do an experiment in a lab and you see how strongly that heroin molecule is binding to the opioid receptor, how strongly then is the fentanyl and so on and so forth doing. So it's the molecule itself as opposed to a street versus so on and so forth cut. Yeah.
I see. Yep, got it. Thank you. So now, Judith. So I think Judith will follow on in some way, talking about data from Wedenos and about data from coroners related to nitazenes, which of course is very important for us to consider, since this hasn't really hit the news as much as it should have, I don't think. And when I've heard when Judith spoke at an event held at London Metropolitan University last September, one of the issues was that local authorities are quite keen on having the data suppressed. And that good people such as Judith try to make it public and unsuppress it. Judith, I'll introduce now. So Judith, a retired general practitioner who does now incredible work for drug-related activist causes. I said Judith, who has certainly partaken in street drugs events before. So Judith, if you wish to say any more to introduce yourself, please do. And then please do tell us about your angle on nitazenes and current issues relating to them.
Hi, I'm delighted to be here. Hopefully you can hear me. You can see my Keep Calm and Carry Naloxone. Oh, t-shirt, there's the message. All these people who have died, none of them needed to die if there was somebody there with naloxone. And that's one of the messages for today, one of the many. Yes, I'm a GP, retired GP in Birmingham. I was a GP for 35 years, working with people who use alcohol and other drugs in the middle of the city. And for the last 15 years, since 2009, I've kept a database of everybody who's died in Birmingham, working initially with the coroner's office. And I've watched, sadly, the deaths slowly rise, especially between 2015 and 2020, when we had such cuts to services. But I have been more frightened in the last 3 years than in the previous 40 years, because we no longer know what's in our drugs. I know that there are other people here today who've been very personally affected by the people who've died because of this nitazene that's arrived in our drugs. And even the National Crime Agency agrees with me. They said in October there's never been a more dangerous time to take drugs, which almost sounds as if they're a little bit humane. Karen has already touched upon the fact that there are two different groups of people at risk, and all of us need to concentrate on getting whatever messages we can and whatever information we can out to both of these groups, completely separate and often not knowing each other groups of people. The teenagers on their laptops in their bedrooms ordering pills, and then there's this group of older people, because of the threat to the heroin supply, who are now dying in the last 3 years because of the nitazene being added to heroin. We know that the nitazene in the pills have mainly came from underground chemists in China. Donald Trump, in his last iteration, encouraged China, and they did successfully controlled fentanyl being exported to the US, and mostly the precursors, but they now send the precursors that go to Mexico, as Caroline explained. But the underground chemists rediscovered these nitazenes, and Caroline's explained all that as well. And then we've had this double whammy of the Afghan poppy crop reducing by 95%, which we might think is a good idea until we realise that nature abhors a vacuum, and the nitazenes have arrived in the heroin supply. So I'm just coming back to Birmingham, affecting teenagers, young people buying these pills online. And this is a slide that I made after I'd been in the coroner's office in March 2022. And the cause of death inquest of these three very young people, 19, 20 and 27, two students and an entrepreneur they were described as in the inquest. They didn't know each other. They weren't known to drug treatment services. I was astonished and shocked and very worried. They'd separately, I could tell from the inquest reports, bought oxycodone pills. But the toxicology showed this N-pyridino eternitazene. At that time, I'd never heard of. So I Googled it. And then I went to Wedinos to see whether other people have been buying these oxycodone pills. And here was the sample that I've spotted on that day, and you can still see it on the Wedinos website. 7th of March, I think I was in the coroner's office about the 14th of March. And this is a sample that was sent in from Reading of an oxycodone pill looking exactly like the pharmaceutical version. And it had been posted out, I think at that point. Nowadays, sometimes they're pressed in the UK, but at that point, it was Chinese underground chemists posting them directly through online pharmacies or online dark web or Telegram or what. I'm not quite sure I understand enough about all these things, but I understand they mostly came from China. And this person in Reading sent this pill in, and at the bottom you can see it says loss of consciousness as one of the effects. And we don't know whether that person survived, but it was the same time as these young people. So I started keeping an eye on the Wedinos website, which is one of the few ways that we can understand what's happening across the UK. And this is the very beginning of the nitazene that they found, although we know that, for example, in December 2020, this is an inquest not reported to you, Caroline, I think, because it was from that area of Cheshire that doesn't report to your database. It was reported by the BBC. Inquest didn't happen until 3 years after he died, which is a shocking delay. But you can see from the rest of this table, and the yellow stripes are the people who sadly died. But not everybody died. And in July 2021, an 18-year-old in Birmingham actually survived a nitazene overdose because his mother found him and did CPR till the ambulance came, and he was on the ITU for 2 days, but he survived. So it's not an inevitable death sentence, but obviously it depends on exactly what dose you take. So the second wave happened in Birmingham, as Caroline's mentioned, the drug-related death meeting in July 2023, when we were told that the previous week there'd been a cluster of deaths, the first of, 21 deaths between June and August, and then altogether, as Caroline said, 40 deaths over the following few months related to nitazenes just in Birmingham. And we do think that this was followed from the first cancelled poppy harvest, which obviously the people who sell drugs in this particular area had read the news, as we all did, and thought maybe the heroin was going to disappear. Well, it hasn't quite disappeared, has it? But they experimentally got hold of some of this nitazene and sprinkled it in the bags they were selling. And you can see from this table, well, you probably can't, it's all very confusing, but 32 of these cases contained that same nitazene, which I think was probably one person importing one bag of N-diazethyl isotoniazine, very, very one of the most potent of the nitazenes, and then just experimentally spreading it amongst the heroin that was being sold in the bags. You can see at the very bottom of the table, only 5 of the people who died had any methadone there. So there weren't people who were engaged in treatment, which tells you one of the things. I always quote Steve Brinksman, who says that if you're on opiate substitute treatment, you're less likely to overdose. And if you do overdose, you're less likely to die because of the increased tolerance when you're in treatment. And these were people from the rough sleeper end of our heroin using community who were mostly not in treatment. 11 cases, there was xylazine there as well. And you can see perhaps that where it says with heroin 25, in 13 cases, the only opioid there was a nitazene. So the people had sold what looked like bags of heroin, which contained paracetamol and caffeine, and as a bash, which is what's normally mixed up with heroin, and just the nitazene, no heroin at all. This is Simeon. I met his mother. I went, in fact, to his inquest. He's one of these young people who died. He was living in a shared house, and he bought this one bag, which he shared with 2 other people in the house, and he died overnight, and the 2 other people survived, and he went into he didn't actually initially die. He was unconscious in the morning. They sent him into hospital and he died 2 days later. And his mother thinks that if we'd had proper drug checking and a drug consumption room in Birmingham, he would still have been here. So at that time, this is another slide of a paper written by our toxicologist in Birmingham to show that not everybody dies. They tested everybody who came into the A&E department in Birmingham in that same period, because the whole of Birmingham was shocked by what was happening. And the toxicologist in the hospital decided to test everybody, not just the very severely ill people, but people who came in for other reasons but had a history of using drugs. And they found these 19 people positive for nitazenes, some of whom didn't even realise that they'd taken anything particularly strong. Presumably they just had a very small dose. And again, in the toxicology, there was xylazine frequently there. Not many of them was the methadone there. And there was a bit of the synthetic cannabinoids there in that group as well. So that's just a reminder that very sadly we've had many people who died, but in Birmingham certainly there are many people still alive, partly because so much naloxone was used by their friends and by their families and by the workers in the city, who went out immediately to the hostels and all over the city, handing out more and more naloxone kits. And many people did survive these overdoses, but you need to have somebody there quickly with the naloxone. And this is a table which I made, which is similar to the one that Caroline showed, showing that 2020, this is the Wedinos samples, showing that the increase to 130 in 2024, I found. And the middle row shows you which nitazene was found. And on the right, you see that most of them, as Caroline said, at Wedinos, are in actually diazepam pills and oxycodone pills. But increasingly, and that's because those are the people who use Wedinos. Those are the people who the club drug people tended to send pills and powders and, cocaine samples and THC samples and things like that to Wedinos. Not so much the people who use heroin, but increasingly, because of what's happened, the heroin users are sending samples in and getting tested. The UNODC, a week or so ago, said increasing availability of nitazene calls for a global response. But they've found 26 different nitazenes from 30 different countries reported to the United Nations Office of Drugs and Crime, this is. And the story is not yet finished. These are the most recent nitazenes found on the Wedinos website. This is my own table that I just make as it goes along. And at the top, look at that bromazole, a red pill from Sheffield containing cocaine and N-pyridinoetonitazene, which again is one of the very strong nitazenes, apparently in a Xanax pill. And then lower down, the 6 examples of heroin here. I think 5 of them, there's no heroin in them at all. There's only xylazine and the nitazenes and the paracetamol and caffeine that Wedinos always find, which is part of, as I say, the bash that heroin is normally mixed with. So I won't say much about the Afghan heroin because Caroline has already covered some of that, but we know that this is an old slide from 2004, but nothing's changed except that 2022, I think there were 6,000 tons of opium came out of Afghanistan just before the ban on the poppy harvest. And this is the route that it's carried heroin reliably from Afghanistan via Pakistan and Iran straight into Birmingham by the looks of that line. And we now know that the poppy harvest was cancelled in April 23, which caused the people who sell heroin in the UK to start to be worried. But there was still a lot of heroin coming in, and the police kept saying, well, it's no change in the purity levels that they were finding throughout 2023 and even 2024. There was no poppy harvest in 24, and we're coming up to we'll know in April, because the satellite pictures will tell us whether it's poppies or wheat that's growing. And I'm told by the people that track these things, David Mansfield is the person to follow. He tracks what's happening in Afghanistan along with Alcis, I don't know how you pronounce it, who do the satellite imaging. And they've said that the reason we haven't yet run out of heroin is because opium keeps like good wine for 5 to 10 years. And the people in the GLUP years, just before the Taliban made the ban, because there was warning that this was coming, and people stored up opium and planted as much poppies as they could before the ban, and there's still opium in the supply chain, which is still coming through. And I keep asking the police whether they're seeing any change yet. And we're all frightened in case the heroin actually does disappear. And this is a complicated slide that I took from their report, which came out a week or two ago. I can't remember the date exactly, just recently. I think Caroline sent it to me, actually, showing cocaine seizures by the police were up 52% last year, and heroin seizures were down 54%. Well, we don't know, do we? Whether that means that heroin is actually getting through to the streets, is not getting through. My local police in the West Midlands last week, I had a report from my local police contact who said actually the heroin in the West Midlands just at the moment is said to be very pure. And I'm one of the Buddy Up responders, which is one of the things, Buddy Up's one of the things which Cranston has set up to try and support people in this dangerous time all across the UK, and people can ring up and speak to some aging GP like me or somebody else online while they use their drugs actively. And I spoke to somebody last night who said that she was about to just use some heroin, which she'd bought from, it had come from Birmingham, and she said it was the best. It was just like the heroin she used to use 30 years ago, and she was astonished how good and simple and pure heroin it seemed to be. So that one of the dangers, though, is that variability, isn't it? People don't know what they're buying. This is just another slide showing the 4 samples of heroin in November and December tested by Wedinos with no heroin in at all, just xylazine and a nitazene. So what's going to happen next? The nitazenes won't go away, as Caroline said. Heroin likely to become more scarce, and if the police seizure data is anything to go by, it's already scarce. We have to remember that completely different groups of people that need this communication need to know about this. The teenagers, the young people, the people going out clubbing, people using cocaine, for example, who use pills to come down to sleep at the end of the night, and are buying Xanax and Valium online. They're at risk, and they don't know it. And they don't carry naloxone. And there's certainly a case for people to carry naloxone if they're going out clubbing. I carry nasal naloxone, which they might prefer, all the time in my pocket whenever I leave the house. And people going out clubbing where people might be at risk of taking a pill with nitazene in it. And then we've got the heroin users who are also at risk. I agree with Kofi Annan and Charlie Faulkner that prohibition leads to more dangerous drugs. I think the reason we've got the nitazenes here is because of prohibition, but that doesn't give us a solution really yet, does it? We've got to find things that we can do about this. We can't immediately reverse prohibition. And Charlie Faulkner, I was at this side event at the Labour Party conference where he stood up and he said, I want to apologise for my part in the war on drugs. We can see it's been a terrible failure. And he said, I would like to legalise and regulate the supply of drugs, all drugs, including cocaine and heroin, to undermine gangsters killing thousands every year. Well, I think this is common sense. And I also agree with Kofi Annan, who said, I believe that drugs have destroyed many lives, but wrong government policies have destroyed many more. So that's me.
Thank you very much, Judith. It was like very necessary, very interesting, also very, very morbid data you were sharing with us then. And there was one thing you said, Judith, about where the heroin seizures are going down. What will that mean? There's less usable, good, high quality heroin on the streets. Just one point of interest, I was doing some research in a city in South Wales in November, very small scale, small qualitative, could be one outlier group, but this was a group who were all historically people who used heroin, who were saying they don't bother at all. Their kind of homeless scene, their social group, it was crack, benzodiazepines, pregabalin, alcohol, and for them, heroin was already out the picture. They said it was low quality and hard to get, but I don't wish to generalize from that group. But now, Plinio, so thank you very much for joining us again. I believe the first time you joined us on Street Drugs Discussions was for the episode about nitrous oxide of Harry Sumnall, I think that's right. And then you were doing a PhD at Imperial, am I also right there, I think? But now you are working for a drug service in London.
Yeah.
And then please, do tell us what you'd like to pass on about nitazenes.
So my name is Plinio. I'm a pharmacologist and a pharmacist. I did my degree and PhD between Brazil, where I'm from, and the UK. So I started in a different area working with cardiovascular drugs and everything. So that was my ticket to the drugs world, because Profnet was needing someone to help him on nitrous oxide research, which are the balloons. I had a lot of experience on nitric oxide because of the cardiovascular actions of it. So drug science took me in to help them with that. We wrote a couple of papers on it, also a bit of policy documents. And then by this time, I was sure I wanted to change to the harm reduction area. So I started working as a drug and alcohol worker for homeless people on a service, which was a pan-London service, so all boroughs of London. And now I'm working for Providence Road, which is a homeless day center operating since 1860. And what we provide there is, apart from breakfast and lunch, also drug and alcohol advice. They can also see psychologists. There's a range of services that visit the center to assist the homeless, such as food clinics, such as mental health services. There's a very big different population that access the centers, either being refugees, people fleeing domestic violence, people who are from the community and became homeless for some reason, people who might be using drugs and living that lifestyle of homelessness and drugs. Which is the type of community that the service that I'm in, which is called the Reset Outreach and Referral Service, deals with on a daily basis. So what I'm going to be contributing here is more the frontline perspective on what's going on for people who are using opioids on a daily basis, several times per day. Also, very importantly, we provide a needle exchange service, which is very well equipped. We also provide wound care. So you can come and get free needles and free paraphernalia you need to use injectable drugs. You can also get condoms and lube, because we also see a population of people who might not have access to that. You can also get naloxone, very importantly. We distribute naloxone to everyone who might be in contact with people using opioids, or if someone is interested in carrying naloxone, we also provide naloxone for members of the public. Just need to contact us. We can give a quick training, and you can go and carry your naloxone just like Judith. We also do one-to-one sessions. We take people to get their methadone prescription or Subutex, which is another opioid replacement therapy. We try to give a holistic advice to people who are using drugs, and based on what their needs and what they want to do with their lives in terms of their drug use, we can provide advice. So not everyone wants to stop using. Some people want to reduce. Some people want to use it more safely. So that's why we're there. We're there not to enforce that everyone needs to stop using drugs, but to make it more safe and informed to reduce harm. Okay, so very importantly, we've recently been asked by our Drug and Alcohol Commissioner to start distributing drug testing kits to people who might be using drugs contaminated at the moment, as Judith said, not only heroin, but also crack, cocaine, THC vapes, and of course, benzodiazepines. So what we're doing, we decided to formulate this individual kit to the drug user. It's just this paper bag, which contain rapid drug tests for xylazine, nitazene, and fentanyl, which are the three main contaminants. We also have you can see here, like, it's a very small spoon. Basically, you scoop the drug, you put on a water bottle tip, for example, with a little bit of water. You dilute the drug in there, and then you dip all your 3 tests. And then you have a very quick result whether your drugs might be contaminated with xylazine, nitazene, or fentanyl. So this is proving to be very effective. There is a whole discussion because these tests are obviously not perfect, but it's definitely providing awareness, and we're definitely getting positive tests, which is scary, but it's happening. So around Christmas time, we went to 6 different hostels in the area, and we gave 10 individual paper bags with 3 drug tests to each hostel. So the service users access drug tests in their homeless hostel straight away. And we also trained the hostel key workers on how to use these tests and teach the service users in case they need some sort of advice on how to use the drug testing kits. We also have these drug testing kits available at our needle exchange service. This is proving to be very effective. We're also enforcing service users, if they do a drug test, to report the test either to their key workers or direct to us straight away, so we can disseminate the information. And this is just a common sign that we display around site. We also take it to hostels, so we promote overdose awareness. So this is based on our naloxone training, and obviously naloxone. And that's it for me.
Great, thank you, Plinio. So yeah, I'll start with the full Q&A now. This first one I got to you. I'll quickly answer something that's in the chat. Hi, I'm not from the UK. The hostels that speakers are referring to are a source of drug consumption. I'm like, no, they're a place for homeless people to live. It's something a big feature of the United Kingdom homeless response is that every city has places. Sometimes there's places for people to go in the daytime. They could be places where at an emergency level, people have, basically a mattress on the floor, or can be given their own room while they look for a more permanent source of accommodation. But these places are very realistic, often about substance use of the residents, and they combine themselves with harm reductions, I guess, in the way that Plinio was talking about.
I just got in on that one. One of the responses I wish to see much more of, and I don't think we've got any in Birmingham, although I gather Cornwall is doing very well with it now, is high tolerance housing, where some hostels have proper policies so that people who use drugs can live there without being evicted. Threat of eviction is very real. People who use drugs in hostels, in the ordinary hostels. We don't have high tolerance housing as a general thing. Commissioners in areas can commission it. They shouldn't be waiting for people on the ground to necessarily write these policies. I gather in Cornwall, I don't know about other parts of the UK, that the commissioners are actually asking for hostels to be providing high tolerance housing, which can make a big difference to the safety of people. Because if you're going to inject the drugs in your own room quietly, you let somebody know. There are lots of ways they could do it, but they could let somebody know in advance, and then somebody might check on them 10, 15 minutes later to make sure they're alive. There are lots of different ways of doing it, but high tolerance housing is something we're very short of, and we could do with a lot more of.
So a clarification and a clarification back to Plinio. Is it that you are asking service users, Plinio, to give you samples which you send to Weninos, or do you have testing kits which in the field can be used? Can you clarify that one, Plinio?
Yeah. So what we're doing, so these are rapid drug testing kits that people can go take their drugs and test their own drugs wherever they are. We don't test the drugs for the service users because we're not allowed to manipulate illegal drugs. So that's another point that high tolerance housing could be very effective in this sense. So people would have privacy and time to test their drugs.
Great, thank you, Plinio. Before we move to Caroline, very quickly, is there a way for individuals to source these? Can they only be bought like in bulk by drug services? Someone did ask that either in the chat or the Q&A. So how would we get hold of these?
No, they're legal. You can buy online. Yeah. So
I
Judith has some.
bought some.
Yeah.
I bought some from Exchange Supplies, and I'm not a
Yeah.
surrogate. So you can. It's possible for people to buy them, but I mean, I want to hear what Caroline's got to say. But I do have some caveats about them.
Yeah, Caroline, over to
Yeah, I'm afraid I've maybe jumped the gun again, Judith. I've got some caveats about them as well. The first with these test strips, the first is that all because the test strip might not be saying that there's no nitazene or no xylazine or no fentanyl there, it doesn't mean that there's something else there that's not horrible and nasty that is therefore safe to take. Whilst they can be used to sort of say what's not there, you still don't know what is there necessarily. The other thing is I was chatting to an analytical toxicologist, and one of the things that's producing a false positive is caffeine. And a lot of heroin supplies are adulterated and contaminated with caffeine. And so we might have people thinking they've got nitazene there when actually it's the caffeine in there that's causing the positive to appear.
Thank you. And now back to Judith.
Yes, following on from that, I've also seen that the test strips can give both false positives and false negatives. But what I would suggest people do is use them as a talking point, so that, I mean, they display that they display your that you're caring about the person's safety, and you can have a harm reduction conversation while you hand them out, but you have to explain that they're not actually 100% reliable. And if anybody gets a positive on one of these tests, I ideally print out the Wedinos form for them and give them a stamped addressed envelope and say, if any of these turn out to be actually positive, please send a tiny bit. They don't need very much off to Wedinos, who can confirm it, because and I do know that some positives on the sticks have turned out to be just ordinary heroin when it gets to probably because of the caffeine, I suppose.
Yeah, I see this as a very early stage for drug testing. Obviously, these tests they have their caveats and everything, but looking on the other side, it definitely increases awareness, makes people think, well, what I'm using, is this what I want to use or not? So then just to open up this conversation and to have time to think on is already a very good starting point. And obviously, Wedinos uses a extremely potent method for detection, which I presume is mass spectrometry, so which will detect things at very low level and very, very precisely, and also identify the type of molecule. Whereas this is just a rudimentary dipping test, which could give a false positive or false negative, but has been shown to actually be proved right many times.
Okay, thank you. I've got another couple of more questions on the topic of testing of samples. So I think I'll ask these two further questions now before we move on. So one from Zofia Gartska, who I believe is working for a drug service in Edinburgh. I'll ask this question both of Wedinos and also of the rapid street testing kits that you had, Plinio. And so I'll open this up to all three expert guests, whoever wants to have a go at this first. Do you know how much of the substance needs to be sent to Wedinos? Because people we support are not willing to give any of their substance that they're using. So what's the least amount that should be submitted for the testing? So could you, one of the three of you, answer me that for both rapid testing kits and also for Wedinos?
For Wedinos, one thing you can do actually is look on the website where they take a photograph of the samples that have been sent in, and they don't like to say that they will test paraphernalia, but historically I've seen photographs just of the cooking spoon thing that people have sent in, and they test just trace amounts, really very small amounts. So somebody doesn't need to give their whole bag of heroin. They just need what's left on the spoon, maybe.
So I think another one said, from Siobhan Neron, what are the doses of naloxone needed for a nitazene or a nitazene overdose? So can anyone say, I think that's a Judith question. So Judith, can you speak on that, please?
Initially, there was some discussion on this, and in Canada and the US as well, there was discussion about whether people should be using larger doses of naloxone for fentanyl, and we have the even stronger nitazene to talk about. And the answer is no. The answer is use the same dose which we've always used, but keep using it every 2 minutes, every 2-3 minutes, until the person either starts breathing or the paramedics have come and they can give an intravenous dose. So if you've got a nasal one like me, ideally you've got another one, but you could start with one of those, and then 2 minutes later you could break open your yellow kit and give an intramuscular, and you can keep going with the same dose that we normally use, which is a fifth of the injectable one, or a whole nasal spray, every 2 or 3 minutes until the paramedics get there. But obviously, if the person doesn't start breathing in that time, then you have to start CPR as well, and the rescue breaths as well, while you wait for the paramedics. But I'd always prefer to have a go with the naloxone, because it can be like a miracle. But the other thing to say is that and sometimes people do, in the panic of the moment, in the dark, and somebody's not breathing and they're blue, they'll put in a whole 5 doses at once. It's not going to kill somebody, but it might bring them round too fast. And in the old days, the ambulances used to use a bigger dose than they do now. And people used to come around so fast, and then they'd hit the ambulance man and run away because they were actually in withdrawal. And the idea is to give just a little bit, enough to get the person breathing again, but without shaking them into withdrawal, which will then make them more frightened to use naloxone themselves in the future, or to have anything much to do with it. It can, in the past, had a bad reputation in that way. So the usual dose, but keep going. And if the person's not breathing, start CPR and rescue breaths.
Excellent. Thank you very, very much for that, Judith. Another question which is a bit different, but I think very relevant. I have a feeling the answer will be there's no real good or easy answer. But an anonymous attendee asked, given that the relationship between potency and human toxicity is complex, how can we best communicate the risk posed by nitazenes to non-specialists? Those without much experience in pharmacology may assume that nitazene, sorry, pronounced it badly, could kill 500 more than heroin based on potencies. So yeah, how would, if someone works with people who use drugs, how would you try and communicate potency in an effective way? I don't know, Plinio, you want to have a go at that?
Yeah, so there is the general harm reduction advice for people using opioids. So if it's a seasoned user who got in touch with a new batch, we always advise them to start very small and smoke preferably. We never advise people to inject straight away heroin from someone they don't know, they're not used to. It's important to talk about a bit how heroin is used. A lot of people might not know, but a lot of heroin is actually smoked, and not everyone that uses heroin is an injectable drug user. I would say more people smoke other than inject. And by smoking it, you have less chance to go into overdose. The general advice is start smoking very small, and even sprinkle it on a little bit of tobacco instead of having a full hit on a pipe. There are ways of going slow and then eventually using it as your preferable method once you see that heroin is safe to use in your advice. For a new user of heroin, then it's someone who's definitely going to be in danger. Definitely needs to be doing it with someone else who is a seasoned user, and go as low as possible as well.
Thank you very much. And I've actually got a good follow-up to that one. So Steve said, question to Judith. She raised concerns about clubbers buying Xanax and another drug as part of their after-party care. What was the other drug? And do you have helpful harm reduction info for kind of clubbing party drug users?
I probably said diazepam as well as Xanax, but a lot of people do use one of the benzos. The only reason I know that this is so dangerous is because I've been looking at the Wedinos website, and because people have bothered to send some pills in for testing, and because increasingly we can see that that I don't understand why that anybody would put a nitazene into a benzo pill, because people who take benzos are looking for, for the benzo effect. They're not opiate users at all, usually, although sometimes, obviously, heroin users will also use benzos. But I think it's very frightening. Initially, the benzos were just being swapped for another benzo. So you'd see, you might see alprazolam when you'd thought you'd bought Valium or whatever. But now we're seeing usually metanitazene in the last year, and I'm saying usually. Please need to know this is new. This is new to some of you who are listening. Some of you, it's not so new, but it's also new to me. And I've been working in this field for 40 odd years. It's changing so fast, and this year is different from last year. And the pills that people are making in their pill presses, I don't understand why they're often putting metanitazene, which is the equivalent strength to fentanyl. So I don't know how they're managing to judge it, and bromazolam, which is a different version of a benzo. And those two together are very commonly seen in diazepam pills. And I'm frightened, as Caroline said. We don't know how many young people have died in this way. They may not be being tested for nitazenes. Not all the coroners are advised to test everybody who they think might be a drug-related death nowadays for nitazenes, but some of the coroners won't, because it costs, £100 or whatever, more than that probably, to do a special nitazene test for the coroner. And where there's another cause of death, if somebody's a cocaine user, they might just say, well, there's loads of cocaine there, that's probably the cause of death, and they were taking some pills. Well, we don't need to test for nitazenes. But I think we may have missed, we may not know, we may never know, we will never know exactly how many people have already died. And I am sorry. It's a very upsetting subject, isn't it? For all of us, and for many of us who've had personal contact with people. But it's a very dangerous time. And the pills are, the cocaine, if you look at the Wedinos testing, that cocaine is normally cocaine. There isn't very much nitazene in cocaine. That's not to say there never would be, but there isn't very much. And ketamine is usually ketamine on the Wedinos website. That's all I've got to go by. There might be very occasionally there might be nitazenes there in the future, but normally when they've tested it, the cocaine and the ketamine, and even the MDMA is usually MDMA. Those drugs have not mostly been mixed up, but for some reason, the benzos now have nitazenes in, and whichever benzos people buy. Just the other thing to say about cocaine is that although I'm saying there aren't nitazenes in cocaine, we've had an increase in cocaine-related deaths every year for the last 11 years, so that now cocaine-related deaths, and that can be crack or cocaine, because after at post-mortem you can't tell which it was, they're almost as many cocaine-related deaths as heroin-related deaths now, and that was completely the opposite 10 years ago. So that's a changing and dangerous world. And that seizures of cocaine, which I showed a slide showing that the increase in police seizures, 50% increase compared with the heroin 50% decrease. They say the cocaine is more strong, more potent than it ever was. It can cause heart attacks and strokes in people especially people over 30. People are using cocaine for longer than older ages than they used to. And my advice used to be to people, when you get past 30, it's time to move away from cocaine. That's that's my GP advice.
Thank you very much for all of that. One thing to pick up, as said, it's a mystery why they're putting nitazenes into benzos, etc. There's some discussion in the chat then about, is it deliberate? And I guess we don't know how chaotic.
No, it is deliberate. It's not by accident. It can't be, because there's so much of it. Somebody is buying metanitazene from China as a powder, And I think these are being pressed in this country, although sometimes the pills are very, very much look like pharmaceutical pills. And you can see that on the Wedenos website. They're in foil packs, they're in the pharmaceutical companies' labels, even with instructions in them. And yet they've got metanitazene and bromozolam when they're tested. But it's not by accident, it's by design. I presume maybe to get people to have an opioid habit, to get people more dependent on them. I can't think of any good reason for it, but it's definitely happening.
Yeah, got that noted. Thanks. There's someone, I believe, who was it? Fraser asked a question on the Q&A about harm reduction advice, people deliberately taking nitazenes. And so I don't know if any of the three of you have anything on the format in which nitazenes would come if someone deliberately wanted to take them, and if anyone has any harm reduction info for such people.
Yeah, I think it's also important to say at this point that every time a new drug comes in, the research services or research people are behind from the drug users, right? So for many questions, you need to do research to then go on to start having guidance on it. So I've seen some questions around nitazenes, whether they're gonna behave the same way injecting or smoking the same way as heroin. At this point, I would say there is nothing indicating that they don't behave as a classic opioid, because one way of seeing it is that naloxone reverses it. So they seem to be behaving like a classic opioids. Therefore, the general advice on harm reduction would be as a classic opioid. However, there are many different nitazenes. It's a huge class of drugs. And the drugs, by changing their structure, they could have different ways of absorption, different volumes of distribution for various different pharmacokinetic parameters, which will then determine whether they are safe in injecting or smoking. Since this research, I don't think has been done so far, probably a bit. Some people did a bit of pharmacokinetic research on mice, and I think Caroline is involved, if I'm not wrong. But until it's proved to be different, there is no way of giving advice, if that makes sense, that other than classic opioid advice on harm reduction.
Thank you very much. Another question now, interesting and a somewhat unusual question. It's written by an anonymous attendee who is an analyst at the Home Office, who says, so first to Caroline, with anyone who can help to answer, please do. We are looking at quantifying the harm from synthetic opioids, which is proving difficult. One option is to scale up our heroin harm estimate. The question: what are your thoughts on uprating heroin harm by a potency factor to estimate the harm caused by nitazenes or fentanyl? Anyone have a go at saying that, even if you want to say that sounds completely impossible?
I mean, it sounds, yes, very difficult to do. I would agree with the anonymous contributor there. I think just scaling it up wouldn't necessarily go, because say for etanitazene, or the one that's 500 times more potent than heroin, if you just factor everything by 500, you haven't got 500 more users of it. That's the intrinsic potency of the drug itself. So whilst the risk of overdose in that person is much higher, I wouldn't necessarily say that it's scaled up in the same way. You do have additional harm risks associated with nitazenes, though, that you might not be considering for heroin. So multiplying something from that's a zero risk for heroin by 500 is still zero, right? And I'm just thinking here of if nitazene is in the post and it leaks, getting a little bit of aerosolized heroin, if you breathe it in, you might feel something, but the overdose risk is probably very low. But with the nitazenes, they're so potent that could actually prove fatal to some postal workers. Yeah, you've got additional things there. I wouldn't say you've got necessarily more users that you would then just multiply it by. Tough to do.
There's something I'll add to that is that we've heard a lot about how little data we're working on. You know, we work on Wedinos, which is necessarily incomplete because it's sent by people who send it off, and are the people who send it off more likely to have positive samples and more likely to have negative samples? We can see dangerous trends emerging, but it's really hard to quantify the danger from that. Judith especially told us about how we will never know how many deaths due to nitazenes there have been already. I think that coroner data is often very poor. They possibly guess at which is the most causal drug in the death, and as we found out from both of your presentations, that nitazenes can degrade in the blood, so there might be a whole number of false negatives in the post-mortem data as well. So it sounds very, very tricky, but interesting project that you are working there on the Home Office. And first question we've had from the Home Office here, so many thanks for that. Someone's asked, do we know anything about detoxing from dependency to nitazenes or other synthetic opioids compared to detoxing from heroin? Anyone got anything on that?
I can just give a quick introduction before Judith goes. So it's the number of people using nitazenes because they want to use nitazene is still small, right? So many people using drugs or opioids are using nitazenes and they don't know they're using nitazenes. So that's the reality at this point. What we're seeing is people using heroin, they are saying at a day-to-day basis that the withdrawals have been stronger. And then they need to use more. So this could be an effect of the contamination, whether by nitazenes or fentanyl. So I've had a client that he said that he was using he had quite a bit amount of drugs. They were using it just as a normal day. But then the next day, they felt the withdrawal a lot more stronger than they ever felt. And this is someone who uses heroin for 20, 30 years. So this could be one way of seeing it. Then the detoxing part will obviously be related to the withdrawal symptoms, right? And I think Judith can contribute on that because I'm sure she's seen that.
As I've been retired from clinical work, my personal experience, it relies on papers that people have written. But I've seen work done by people detoxing or helping people dependent on fentanyl, for example, in Canada and the States. And the consensus seems to be that if somebody has a tolerance and a dependence to a high-strength synthetic opioid like fentanyl or nitazenes, and that's developed over a period of time, then they can still be helped by a transfer to an opiate substitute treatment like, for example, methadone. But you need to do it more quickly than we have habitually, in our careful way, been inducting people onto methadone, or you will lose them. And the fentanyl paper that I read said you need to get people up to a similar level of maybe slightly higher level of methadone than you normally would for heroin, not dramatically higher, sort of 80 to 100 milligrams or something a day, but you need to do it quickly over a week or two, not taking weeks and weeks and weeks. And you can do that safely. We used to do high dose induction in Birmingham, I don't know, 30, 40 years ago, for people who were high dose heroin users, you know, a gram and more than that a day. And we'd do it by asking them, because we were nervous to give them such high dose methadone very quickly, but we'd just split the dose and ask them to go to the pharmacy twice a day. So you could give 30 milligrams in the morning and 30 at night. For a couple of days, they're on 60 milligrams, aren't they? Which normally might take you a couple of weeks to get somebody up to. And you can increase that in a twice daily way until you're sure that somebody feels comfortable and feels stable. And then you can change it to a once daily dose later. So there are ways of doing these things. It's a complicated and difficult problem to help people who've become dependent. It's not going to be impossible. It's going to involve a lot of clinical skills in terms of listening to people.
Thank you much, Judith. And I was going to ask one more question, but you basically answered that. So I think I'll probably, I don't know if Plinio and Caroline have any final messages you'd like to give before.
My final message would be, well, if you are living in Tower Hamlets and you want to be trained on naloxone, you can contact us. We're happy to provide training on naloxone and also giving out naloxone for people who could be in touch with people using opioids. We also open as a service to the community. So if you are taking drugs and you would like some harm reduction advice, or to discuss or to talk about your habit or your occasional use, you can contact our service. We are open to all residents of Tower Hamlets. Doesn't need to be homeless. So our team is available for a chat and to help your needs as you need.
Thank you very much, Plinio. So yeah, many thanks all. It's been absolutely wonderful. And yep, hope to see you all again soon at future events.